18 years, yeah. And Jentry is invited tonight because he is a real leader in the space of transparent, effective healthcare benefits. He is a Health Rosetta advisor and has been putting progressive health benefits plans together for years now. I'm particularly interested in his plans because he's using direct primary care in some of his plans. So we're very lucky to have him here tonight, and welcome, and tell us a little bit more about yourself.
Perfect. Thank you, Kendrick. It's good to see everybody and nice to meet people that are on the line. So I thought tonight I wouldn't do a presentation and bore everybody and have you fall asleep with slides. But it's great to be with you. I've heard about these meetings, have never attended one. So now I'm attending one and actually speaking at one. So a little bit about myself. As Kendrick had said, I'm with the Mahoney Group. We're a 108-year-old company, independent insurance agency, get offers to sell every day for, whatever the EBITDA is now, 15, 20 times EBITDA. Just really love what I do. I've been there again for 18 years, been in the industry for about 19 and a half, coming up on 20 years. And local, moved here in '88 to Arizona and actually started at the Mahoney Group my last year at ASU with a bachelor's degree in business management. So over the course of, the 19 years, I've tried to, increase my knowledge. I'm a registered employee benefits consultant through the American College. We do a lot of business with Native American groups. And so I'm a tribal human resource professional, a THRP. And then as Kendrick had said, 2 years ago, I joined the Health Rosetta as a agent or advisor with Dave Chase and his organization. So when it comes to healthcare, I think everybody on this call is in the same boat, right? How do we change healthcare? And an advisor plays a pivotal role in changing healthcare. Perverse incentives, a lot of abuse from a fee perspective. The Consolidated Appropriations Act is shining a lot of light, which oddly enough, a lot of agents aren't talking about the Consolidated Appropriations Act. And we just see it as an incredible opportunity for those advisors that are transparent to really shine the light on fees and what brokers are being compensated, because a lot of business owners don't understand where all the revenue streams come in from, the TPA side, PBM, stop loss insurance. And so that's a little bit of an introduction about myself. A lot of the emphasis and focus that I have is on charter schools, tribal organizations, and restaurant groups. So those are kind of my three verticals. Mahoney Group is a full service agency, more on the property casualty, business liability, workers' comp side. About 25% of our profits is with the employee benefits, which is what I am specializing in. And so a little bit about myself. I think the key purpose of tonight's meeting is to talk about how we structure a plan differently with those individuals that want to do so, right? They want to have higher quality, lower cost employee benefits. And so I'm going to talk tonight about, the pitfalls, the problems that I've seen, the mistakes that I've made, and open it up to some questions at the end. So I started doing self-funded plans about 10 years ago. It was in the tribal space. And these were groups that, for the most part, were with a BUCA carrier, very rural areas, lots of turnover, not to be, prejudiced, but in most cases, just don't understand how insurance works. And a lot of them get care from Indian Health Services, which in our region, most of the time, that care that they're receiving is very poor, and it's very hard to get an appointment with a clinic for the basic care needs that they have. And so they rely on a service called preferred and referred care. It was called contract health services before. And they just could not get the care that they needed. And so a lot of the clients that I was working with about 10 years ago, they were looking for solutions outside of Indian Health Services because the government option just wasn't meeting their needs. And so at that time, we worked with a couple of third-party administrators to do what's called Medicare-like rates. As tribal organizations and a health plan, they're able to take advantage of Medicare-like rates, which is different than the commercial market. And so we would work with them and with specific TPAs that understood Native American populations. And we would usually, bring in a carrier network, rent the network, or just a freestanding network. And we'd write into their plan document as an exclusion, Indian Health Services, which would allow them to really steer a large majority of their population. They'd get the care that they needed, but they wouldn't have to pay for it through their commercial health plan. And so it's been extremely successful. It saved them millions of dollars over the last 10 years. Some of our clients, they don't want to go, all the way where it's all pushed back to Indian Health Services. And so what they'll do is they'll just implement a piece of it with the Medicare-like rates. And the TPA codes those Native Americans that qualify. They go in, it's paid by Medicare through Indian Health Services or preferred and referred care. And they end up saving a lot of money for those claims. So that was my first exposure to self-funded plans and setting them up and trying to help. And then kind of my next step was the pharmacy side, and really looking at what we call these pharmacy benefit managers and trying to understand all of the ins and outs. And Bill is on the call, helped me a lot to understand better how pharmacy benefit manager works from, patients assistance programs, rebates, manufacturer assistance programs, international medications, and how to fill those prescriptions, across national lines. And so after, figuring that piece out, then I moved to medical management and tried to, educate myself and team up with some Health Rosetta advisors and really bring it back to the home field. And so I feel like I'm always learning something new. There's always something new to learn in this industry, and it's constantly changing. Within the last 2 years, I've started implementing direct primary care, mainly with Dr. Johnson. And it's just been fantastic. I love, again, what I do. I don't feel like I'm tied to any BUCA carrier. About 80% of my business now is non-BUCA business. Just really feel like I'm able to help both the employee and the employer to drive down their healthcare costs and improve their healthcare quality. So just to give you a couple of examples, we have, Dr. Johnson and I have now 3 clients ranging from 40 employees to 150 employees that have direct primary care. And I'll kind of just explain what those structures are. So each of them are with the same TPA, same pharmacy benefit manager, same direct primary care provider, same medical management, and they all are doing reference-based pricing through a third party. And so we've structured the plans a little bit differently. Instead, most of the time you raise your deductible, right? And what happens to the premiums? The premiums go down. Well, we flipped the model and we've actually lowered the deductible and lowered the premiums in order to steer people into the direct primary care plan. We have 2 plans, direct primary care, where there's no copay for any services that are rendered through the DPC. And then if they need to go to a specialist, they work with the DPC to be referred out and receive that care. And then through the medical management company that we use, we waive all of their deductibles, co-insurance, out of pocket for any lab, x-rays, surgeries, as long as they go through the medical management company. And we've seen, about a 60% adoption of those DPC plans throughout those 3 different employer groups that we work with. For those that don't want to do the DPC route, they pay more because we know that we can't manage the plan as effectively. but they want to be able to go to any primary care doctor that they want to. And so they pay a little bit more, but they can go to that doctor. And then we work with the TPA to try to get that doctor to contract, do a direct contract with them. And then again, with the medical management for the higher cost pieces, again, we waive deductible co-insurance out of pocket on that plan as well. So very similar plans. Really, the main difference is the DPC. The employer pays for the subscription for the DPC plan, and they just know it's going to, return on investment is going to be worth paying that fee in order to drive employees through the DPC plan. So that's kind of the structure of it. We have about a year, coming up on a year, with 2 of the plans, and then the other plan is just recent as of January 1st. So again, I don't have a 5 or 10 year experience or a case study of multiple years, but that's what my experience has been. And so far, the employer groups, I had one employer group, a charter school network here. We rolled out 7-1 last year. They were with Cigna before on a level funded plan. And I remember being in one of their open enrollment meetings, and there was this employee in the front, and she just put her head down. And she was just like, this is horrible. This is gonna be the worst thing. I can't believe, our employer is offering this plan. And, you always have one in every group. And, Kendrick is smiling because he was there and he knows who I'm talking about. And 3 months later, I get a call from the, controller of the school. And he's like, Jentry, you're not going to believe this, but you remember that gal that was in the meeting, with her head down, and she was like kind of upset that we were moving to this plan. Well, she went to her doctor yesterday, and her doctor said, this is the best health plan I've ever seen. I've never seen anything like this before. And so that's just one example. There are many examples. I've had parents, siblings that have called me from other employer groups where they're looking at the plan and they're like, how can this be? Like, this isn't possible. And so super excited, obviously, still pretty premature in the process, but these are the types of health plans that I want to install with my clients and future clients. And so it's been a road, and we're still learning, but it's been exciting to experience. And just, I love being at the member level. I tell people my favorite part of my job is being with employees and being able to tell them, hey, instead of going here, you can go here. And by the way, it's going to cost you less. And they're just like, how can this be? And it's like, because of the way our system is set up. So I've talked long enough. Kendrick knows I'm kind of a man of few words, but love to answer any questions that you guys have.
I'm interested to hear what motivations led you to implement direct primary care.
Perfect. So the question was, what led me and what motivation did I have to start doing plans differently, specifically direct primary care? Is that correct? So for me, I'm one of those guys where, like, I don't like taking chances, especially with clients that I have a strong relationship with. I'm not that guy. There are some guys, good for you. They're great salespeople, right? I'm more of a comfort guy. But for me, being part of Health Rosetta and seeing what other advisors were doing and talking to them in depth and kind of digging down into the weeds and what are the logistics and just learning from them. Many of you probably know David Contorno. He's pretty outspoken and very public and LinkedIn and social networks and that type of thing. And so I attended his conference last week at the Youth Symposium here in Phoenix, and I'd known of him. I had never met him before, and I was just like, I have a moral obligation for me personally to try to do this. I understand that it may not run smoothly, but for me, it was a moral obligation that I felt like I needed to try. And my clients expect that of me. They trust me. A lot of them are my friends. And so I just started talking to my friends and saying, hey, there are other advisors in Health Rosetta that are doing this. And these are the pros, these are the potential cons. How do you feel about it? And most of them were like, I want to do all of it, right? I want to try it now. And so the main motivation was just for me, I felt like I needed to at least try something different in order to serve the clients that I work with. So.
And what other parts of these plans fit in this philosophy? What is the rest of the plan look like, and how does that fit together with the end goal that you're trying to accomplish?
Yeah, so again, one of the biggest challenges or hurdles I found in these plans is the member experience and communication and understanding. I go here for this, I go here for this. And when you're with a BUCA, right, it's the same way. They don't know where to go. And so providing a higher level of service through different vendors that we work with, and just trying to bring in all of the different parts with vendors that want to learn also and grow and understand and make the solution better, the higher quality, lower cost. And so that medical management piece, I think, is essential. Obviously, the DPC, the pharmacy benefit manager that's going to talk to the medical management company and work together and not say, well, we can't do that or we won't do that because it's going to affect our bottom line, right? Finding the right solution providers that are going to work together in behalf of the client and really want to change the way that things are handled, anywhere from, the stop loss, the risk piece of it, and them saying, yeah, I know how these plans are set up and I want to be more competitive, right? Because it's hard to find stop loss insurance carriers that understand and are willing to get out there and give competitive rates, especially on a 40 life group. So did that answer your question?
Yeah. Can you give me specific examples of vendors,
yeah,
or other services that make sense in this world?
Yeah, so the question was, can you give me examples of solution providers, vendors that are willing to set up these types of plans? So I'm pretty transparent. Like if you want to go find these, or I'm happy to share. Again, I don't think that healthcare is going to change by one broker in Arizona doing one thing. I think we need to work together. And so this other advisor, Mark, that's on the line, feel free to reach out to me. I'm very collaborative. But the TPA that I've been working with is Coastal Administrative Services out of Washington. I hope they never sell because it'll ruin the whole thing. But Coastal Administrative Services has been very, very instrumental and helpful. They're in it for the right reason, and they're willing to work with us and be very flexible. In terms of pharmacy benefit managers, we work with Drexy, we work with TrueScripts, we work with TrueRx, SmithRx on some of our health plans. And again, all of those have been pretty flexible in terms of helping us. We do have some clients that are on the border. And so we have a solution provider called IMS, International Medical Solutions, where we can get care in Mexico for our members at a significantly reduced rate. And that's for medical, dental, vision. Probably the biggest piece is pharmacy. Their brand name drugs just blow it out of the water. And Bill's familiar with them, has worked with them on several groups as well. In terms of the reinsurance for these smaller groups, like a 40 life group, usually a captive solution makes more sense just because you don't have to do individual health questionnaires for underwriting purposes. And so we work with a few different ones, Berkeley, Roundstone, Pareto. Some of them will go down to 50, some will go down to 20. For medical management, we use primarily AIM, Alt International Medical Management, but there are other ones out there that we work with. So yeah, that's mainly been it. Obviously, you're our only DPC to date that we're working with in the local market here. So
maybe encourage anybody else on the call to ask questions, but I've got a couple more. Looks like Bill Miller might be chiming in. Oh, he's logged out.
Yeah.
Well, my other question was around, you said 80% of the business was non-VUCA.
Mhm.
From the limited experience I have, that sounds like it's abnormal to have such a small segment
Yeah.
of your groups be in a VUCA plan. Why is that so? Is it more because of the types of people that you are serving, or is it more because you help more people understand that that would be a better route?
Yeah, so I would say the primary reason, the question is, I had mentioned 80% of our business, employee benefit business is non-VUCA. And why is that? So the first reason is our employee benefits practice lead at Mahoney Group was beating this drum about 8 years ago, just saying, they're a bunch of crooks, man. The VUCAs are crooks. And we all thought, man, he's crazy. Jason Andrade is his name. We're like, dude, whatever. And as we all started digging in, our eyes started opening. It's like, yeah, they are ripping off the American public. And so that's the primary reason. The second reason is we just resonate with, people that don't want to accept the status quo. We're not going to win against the national insurance brokers selling Blue Cross, United, Aetna, Cigna, and Humana. It's just not going to happen. They have the market share. And so for us to be able to compete, we have to come in with a different solution and a different message.
And when you say compete, are you talking about price, or are you talking about what is it? Why is it difficult to compete with them?
Well, they're getting contingencies and they're being paid by the VUCAs, right, for keeping business with them. And so they're gonna, and I've seen it on their proposals. I don't know how far this is gonna be transmitted, but on their proposal, it'll say, look at unbundling self-funded option next year. And it's like, why don't we look at it this year? And so we're the ones that are bringing in and driving the change and looking at the whole picture instead of just, okay, we're just going to renew with a VUCA carrier. And so it's a very stark difference. We can't compete because they already have the partners with the VUCAs. And so we feel like we just have to differentiate ourselves, number one, by going outside of the VUCAs. But number two, we feel very passionate that that isn't the best solution when it comes to healthcare. So.
What do you think the primary reasons people sign with the VUCA are?
I loved what Jeff Gold said last year at the U-Power Symposium. They're addicted. They're addicted to the status quo. It's the easy button. I've talked to older business owners, and they're like, Jentry, like it's just one more cog in the wheel that I have to worry about. And I know that every year I'm going to get an increase. And so I just try to get a 10% increase. And if I get a 10%, I've won. And they don't feel like there's any other way to do it. That's one of the reasons. I think another big reason is it's more work. It's more work for everybody. It's more work for the employer, HR, for me, the advisor, but it's the right thing to do. And we all know they're going to get a better quality health care at a lower cost.
So you say it's the right thing to do. What are the tenets of the right thing to do? What makes it the right thing to do?
Yeah, so for me, the right thing to do is what's going to cost people the least amount of money at the highest quality. And right now, the VUCAs have no incentive. Their shareholders, their stockholders, they have to turn a profit every year. And how do you do that? By increasing rates. And how are rates set? They're based on claims. Claims equal premium. And so if my claims go down, I have to adjust my premium. Now, do they do that? No. They do it both ways, right? They're going to increase it regardless. But at the end of the day, that's what is right for the client. Better quality healthcare at a lower price. And you're not going to get that from a VUCA.
You talk to a lot of employers on a regular basis.
Mm-hmm.
What is the language that resonates with employers about healthcare services, like pitching DPC or other healthcare services as part of your benefit plan? What resonates with them?
So For those that may have not heard, you said it pretty loud, but I'll repeat it back. What resonates with employers when it comes to, healthcare plans? I would say the one thing that resonates with them is they are sick and tired of an increase every year. All of them can agree that they get an increase every year and they don't feel like it's right? And so it's helping educate them that there are ways, there are different things that they can look at, just like their business. And we like to compare it a lot on the property casualty side, their EMOD with the workers' comp. How your company does safety trainings and different, programs affects your EMOD. And so we try to take it in that business direction, because they're already familiar with it, and say, how would it be to be the same on your health insurance side, where you actually get credit based on the programs that you're doing for your employees, whether it be DPC or, some other type of solution, diabetes management, MSK management, right? All of these different programs. How would it be to be in that model and be able to, really effectively manage your plan? The other piece of it is data, right? They get very limited data from the BUCAs, and it's like pulling teeth. I mean, I have a plan that moved back to a BUCA plan from a fully unbundled plan because they were getting a lot of pushback from employees, very minor, and HR just kind of knee-jerk reaction. Yeah, I'd go back to a BUCA, right? And so now their rates went like this from Blue Cross, and now they're going back up this way with the other BUCA carrier. And it's like, at what point does 2 or 3 employees drive the whole decision of 400 employees? And so you have to have those conversations with it. You don't make a business decision based on 4 employees for your business, right? You make a business decision based on the whole group and what's best for everybody. And so I think those things, the reporting, the flexibility of the plan, the frustration of getting increases every year, those are things that resonate, and just helping educate, right? This is such a behemoth animal healthcare, right? That there's so many different roads you can go down and have a lot of talking points. So
we've over the years that we've been doing this, we've had many healthcare providers, a lot of specialists very interested in getting out of the traditional healthcare market. This sounds interesting to them. They would like to provide services. Can you shed a little light on why knowing advisors and people in your shoes, why it's important to know them, or how they can work together as part of the ecosystem to bring solutions to you that you may be interested in?
yeah, so I think our industry is changing so much right now. I mean, I'll just give you one example. And again, to repeat the question, specialists, how can specialists work together with advisors like me, and how does that benefit them and myself and the clients that we work with? There are third-party administrators that are coming into the market and creating their own solutions. Kendrick and I were on a call with one out of Massachusetts this week. And I think we're going to continue to see these different providers that come into the market. But where that's important with the specialists and the doctors is just continuing to educate themselves on what's coming into the market. So I'll throw a card out there for the other advisor that's on the line. I'll give you an example. Like, we have a provider called Sana Benefits that entered the Arizona market last year. We moved 21 of our BUCA groups over to them. They're primarily a small group solution, level funded program, but they've done a fantastic job of, they have a carrier network. It's a national rental network. But then if employees, their doctor isn't part of that network, they go 2 steps further. The first step is, okay, tell us who the provider is. 92% of the time they're successful in getting that provider contracted under that network. And then the next step is, okay, if your provider doesn't want to agree to contract, we're going to give you a $2,000 cash card you go in and pay your copay, and the provider gets to swipe the cash card so they get reimbursed at their rate. And so there's no out of network with the plan, right? So that's one thing that they've done really well. The other thing that they've done really well is they've gone out and done direct contracts. So any copay plan, non-HSA high deductible plan that is offered to the group, they have what's called Sonicare, and they have about 15 SANA. Yeah, they have Sonicare, and those are their direct contracts with LabCorp. So if I'm on a copay plan and I go to any LabCorp for any type of lab, doesn't matter. What's the most expensive lab, Kendrick, that you can get at LabCorp?
Well, especially labs I never, order a vehicle. Let's call it a genetic test.
Yeah. So you go in for a genetic test, and how much does it cost?
$300, $500.
Okay. So if you're on a copay plan with Sana, free, no cost. Green imaging, direct contract. You go to green imaging, get an MRI, right? What's the most expensive with a resonance MRI that you can get?
Up to $1,200.
Yeah.
To the direct contracts.
Yeah. Free. If you're on a copay plan, direct contract, go to one of these providers, no cost. Mental health, telemedicine, mental health, same thing, have a provider. Blueberry Pediatrics for the children, right? Free. They've got about 15 of these solution providers. Surgical, probably be a good thing for you to talk to them. Durable medical equipment, right? Have a provider. I need a boot, free. So they have a concierge line where people call in and say, hey, I need to go in for this. And those concierges direct them to all of their free options. No cost, doesn't matter what their deductible out of pocket is. They have mobile urgent care. I know don't love the urgent cares, but they have a mobile urgent care provider that they've direct contract here in the Phoenix area. Call, hey, I'm having this issue. Great, we'll send someone out free. So I feel like we're kind of starting to make a little bit of traction in the market nationally. They're in about 7 different states, but they have a really nice model. Is it perfect? No. Their PBM, Smith RX, Bill Miller, but they're doing international, they're doing manufacturers coupons, they're doing all of the different pieces. And so, and then they give a portion of the claims fund back at the end of the year if the employer runs under where they thought they would run. So pretty slick little program. It's not for real large groups. It's mainly, 10 to 100, but they've been extremely competitive, and we've had a lot of success with them. And that comes down to the service providers, right? They're working directly with those service providers to offer those services because they know if we steer our members to you, you're going to take really good care of them, and we want to waive those costs. So, yeah. Any questions on the Zoom meeting?
Question other than you're awesome.
Oh, thank you. Who was that? Is that Bill?
Yeah.
My buddy Bill. What? Oh, no questions. Got it. All right.
I think that was a great introduction to why we would want to start putting different types of plans together.
Mhm.
And I guess there's one more question about the work you talked about. It's more work to build another type of plan and to educate your team
Mhm.
and do something different. And of course, that work has a cost. And so we're talking about rates going up and people, wanting to find out if there's something different. How do we talk to employers about that work? I mean, how do you help them value of using some of their precious resources to do that work.
Yeah, so I think a lot of it goes back to the education piece. I appreciate, you sent me 2 or 3 documents about a year ago that really helped. Like, I think it was a big survey of different DPCs across the country, and a Milliman was included in that. And so I think it's just the education part of it, but then a lot of employers really want to provide better healthcare. And so as I've go out and talk to employer groups, I've seen it's anywhere from like 10 to 20% that really want to help their employees have better healthcare. They're not so much focused on the cost. Yeah, that's great. But like the food bank that we work with, right? It's never been about saving money. Have they saved money? Absolutely. But it's been more like, hey, I've got this Humana plan and my employees pay all of this money and then they can't even use the plan. And I just want to provide a plan that's quality, that doesn't cost them an arm and a leg on top of the premium that they're spending. And so finding the right groups, right? And there aren't a lot out there. I think with the millennials and with the Gen X and the different generations, I think they're starting to question more, like, what the heck is going on here, right? And so I see it as a huge opportunity for advisors in the future to find those individuals that are like, I run none of my other business like this. I don't hit autopilot and just let them run away with money that I send off to them. I manage the business, every aspect of it. And so I'm not going to handle healthcare the same way that I handle, or differently than how I handle the rest of my business. So.
I think that's great.
Thank you.
I can just take the mic.
Yeah, for sure.
Yeah, thank you so much, Gentry. That was just awesome. And one of the things that we wanted to remind people of, is if you're watching this or if you're with us tonight, is that joining the Free Market Medical Association has a lot of power. It brings more funds into the Free Market Medical Association, and it also is just a way of raising your hand and showing that you are part of this movement. So we encourage people to actually go to FMMA.org, FMMA.org, and hit the subscribe button, pay the fee, and be part of it. And that way we can build this movement here in Arizona. And also it moves you to the top of the list of the people who are able to provide solutions in a transparent, free market way. And we also wanted to just invite you to join us on March 9th. At the same time, we're going to have Marshall Allen, who wrote the book, Never Pay the First Bill. And it's a fantastic book, and he is just a brilliant guy. He's an investigative journalist who's really dug deep into the healthcare industry, especially the problems and the bad incentives in healthcare billing. And his book is a real guide to being a better consumer of healthcare. So both for employers and individuals, it's a great insight into how we can better, more effectively buy healthcare to drive down costs and drive up quality. Oh yeah, if anybody has thoughts about speakers you'd like to hear, people that you've read or see them online or them personally, we're interested in hearing who you have that would be a good speaker for this group.
One of the groups that's been challenged to get as a buyer and seller of healthcare is to get the buyers here. We've got sellers, we've got medical providers, we've got different solutions from PBMs to other types of solutions that can help. Having them and creating a network for letting them know that, hey, I've made this move and here's a solution. Is something that would be nice to bring into the arena as well, so that they can tell their story, but we can also utilize that. One of the other things is just for people to go to to our website for just the Arizona chapter for any events or upcoming things. That's FMMAAZ.com.
Yeah, so at FMMAAZ.com, you can see our upcoming events and also see some of the extra resources that we have there. Thanks so much, everybody, and have a great night. Thanks, guys. Good to see you.
Thank you, gang. Great program again.
See you, Bill.
Bye, Liz. Thanks, Jeremy.